So it's my pleasure to introduce Dr. Elsa Nagnestou from Johns Hopkins, medical oncologist and research scientist, a real genomics expert, and with particular interest in ctDNA. Is going to talk to us about minimal residual disease detection. Thanks.
Great. Well, thank you, John, for the invitation to be here. Thank you, Dr. Blay, as well. It's a great pleasure to be here. And of course, thanks, Ross, for the great introduction. Now you make my job easy. And this is where I think we're going to be in 30 years from now talk. So happy to share the slides if you want afterwards. What I'm going to be talking to you about today is where do we stand and what's the promise with respect to liquid biopsy approaches and informing therapeutic decision-making for patients with early-stage non-small cell lung cancer. These are my disclosures. And so certainly liquid biopsies are emerging as potentially powerful approaches to capture tumor burden, to monitor tumor evolution during therapy. And there is a number of studies now that have been emerging that show the clinical utility of liquid biopsy approaches in capturing minimal residual disease as well as monitoring therapeutic response in the context of immunotherapy. And, before we get into this, just wanted to start by reviewing the compendium of alterations that are detected in blood. And so there is a number of DNA-derived alterations that can be detected in the circulation. For the purpose that are all listed here, for the purpose of the talk today, I'm going to be discussing sequence alterations for the most part. In terms of the assays that we're going to be reviewing, these are the ones that I'm going to be reviewing are tumor-informed liquid biopsy approaches where practically there's personalized liquid biopsy assays that are developed based on comprehensive molecular profiling of the tumor. And collectively with these approaches, we've actually seen these have enabled sensitive detection of mutant DNA in the circulation, allowing for a limit of detection that is quite impressive. It now goes past 0.01% or 100 parts per million. And certainly what we know is that circulating tumor DNA or ctDNA MRD is prognostic, right? So presence of ctDNA is associated with inferior outcomes. This has been shown in a number of studies now, and these are summarized in the slide. And what we're also know from these smaller, retrospective, to a large extent studies, is that measuring ctDNA MRD over time is actually more sensitive. That increases the clinical sensitivity of ctDNA. So I'm going to be referring to clinical sensitivity multiple times during the talk. And what I mean by that is the fraction of patients that recur after definitive therapy that are also ctDNA positive. So this is the clinical sensitivity of ctDNA MRD. And so measuring MRD over time, as you can appreciate from the slide, increases the sensitivity, the clinical sensitivity of detection compared to landmark MRD detection, which is assessment of MRD in a single time point. So there is promise, but here's the challenge, and this is it's a busy slide, but the challenge is very nicely, I think, summarized here, where what we're showing is that the clinical sensitivity, this is the pooled sensitivity of ctDNA MRD, is in the order of 40%. And so we're not there quite yet, right, with respect to clinical implementation. We want to be seeing a higher clinical sensitivity. However, with the emergence of more sensitive whole exome sequence or even whole genome sequence informed approaches, we are now pushing down the limit of detection to less than 0.01%, even down to 10 parts per million. So this is data from the most recent TRACERx study where what was shown was a clinical sensitivity of ctDNA MRD after definitive therapy of 49%, which is the best that we've seen so far. In patients that were ctDNA MRD positive after definitive therapy, this was surgery in this setting, were the ones that had the most inferior outcomes. And ctDNA MRD was preceded clinical disease recurrence by 7 months or so. But I wanted to review some of the challenges as well, right? And so one of these is, what does really ctDNA MRD negative mean? So here I'm borrowing data from the dynamic study. As you know, this was a clinical trial in patients with colorectal cancer where the decision to administer adjuvant chemotherapy after definitive therapy surgery was informed based on ctDNA MRD. And the point that I want to make in this coming from the data from this study was there was actually a good fraction in the order of 6 to 10% of patients that were ctDNA MRD negative yet recurred. And so truly we need to be careful when interpreting a ctDNA MRD negative result. Now, coming into the immunotherapy setting in the context of early stage non-small cell lung cancer, well, first I'll review IMvigor10. This is not a lung cancer study, but what we learned from that study was that ctDNA MRD post-definitive surgery was actually predictive in terms of atezolizumab that was administered in the adjuvant setting. For these patients, this is the urothelial carcinoma setting. So in this setting, ctDNA MRD was predictive. Certainly, we didn't see this with EMPOWER-10, right, in the lung cancer space where we saw benefit practically with adjuvant atezolizumab independent of ctDNA status. And what I'm showing here, this is ctDNA MRD status post chemotherapy, actually. But what was interesting, and we're showing here as well, was that in the subset of patients with ctDNA that were ctDNA MRD negative after chemotherapy, the rate of conversion to ctDNA positive was actually slower. So I think this is encouraging. And then certainly there's a lot of lessons that we're learning, from the neoadjuvant space here. This is the 816 data where you can appreciate that patients that cleared ctDNA preoperatively, there was not postoperative time point in Checkmate 816. These were more likely to attain a pathologic complete response, and certainly there was an event-free survival benefit. We saw pretty much the same data from AEGEAN, where patients here, we're looking at patients that had detectable ctDNA at baseline, and then we track them over to cycle 4, day 1. And what you'll appreciate is that the majority of patients with, actually all the patients with path-CR, I believe, in this study, and over 90% of patients with major pathologic response attained ctDNA clearance. This was not the case for patients that did not attain a path response. And what we learned from the Nadim study was that the ctDNA clearance, this is again after neoadjuvant immunotherapy, is associated with a longer progression-free and overall survival. This is the only study that has actually reported overall survival data with respect to ctDNA MRD. And this is from our own study where we looked at the value of ctDNA MRD during neoadjuvant immune checkpoint blockade. This is not non-small cell lung cancer. This is operable gastroesophageal cancer treated neoadjuvantly with immunochemoradiation. There's a few points, though, that I want to make that are a little bit broader, the setting that we studied. And these are the following. You'll appreciate, on the top left there, that there may be patients that with sustained ctDNA elimination after neoadjuvant immunotherapy that may actually not need additional therapy. Right? So ctDNA actually give us the opportunity to identify those patients. And more importantly, if you look at the bottom right there, ctDNA MRD and ctDNA status during neoadjuvant therapy truly allows us to dissect the heterogeneity of path response. So what we're showing on the bottom right there are patients that did not attain a path response, a complete path response with neoadjuvant immunochemoradiation. But what you'll appreciate is that there's a very clear separation in terms of and prediction of outcome based on ctDNA. So we're taking a group that is very heterogeneous, and this is the group of non-path CR, and dissecting it by using ctDNA approaches. And I think this is, one of the promises, and we're thinking about how we're going to put together our next ctDNA-driven clinical trials. I think there's some good evidence there. So let's think about this, right? So how do we implement liquid biopsies into clinical trial design? So what I'll tell you is that we are more confident in the metastatic setting. So this is the CCTG BR36 clinical trial. This is a ctDNA molecular response adaptive immunotherapy trial in the metastatic setting for patients with non-small cell lung cancer. And the first stage of BR36 was specifically designed to answer the question of what is ctDNA molecular response, when does it happen, what is the concordance with radiographic response. And the first stage of BR36 met its primary endpoint, where we showed that clearance of ctDNA 6 weeks on pembrolizumab monotherapy was highly concordant with radiographic response, at 82%. But importantly, better predicted overall survival. And so now we are down here, which is stage 2, the phase 2/3 study, which is the first ctDNA-driven study of adaptive immunochemotherapy for patients with non-small cell lung cancer, where patients that are treatment naive, metastatic non-small cell lung cancer, PD-L1 positive, oncogene negative, they get analyzed by liquid biopsies at 6 weeks after pembrolizumab initiation, and upon ctDNA detection, these are the patients that are randomized to either continuing pembrolizumab or stepping up with pembrolizumab and chemotherapy. And the hope here is that we will get regulatory interest in terms of establishing ctDNA response as an early endpoint of immunotherapy response. So again, we think we know how to do this in the metastatic setting. How do we do this in the early stage setting? And so this is work, the slide is from a study that PJ Valanki and folks in the Oncology Center of Excellence put together for a JITC special series that we put together a year ago or so now. And so you can appreciate the fact that ctDNA MRD in the early stage setting can be used as a stratification or enrichment strategy post-definitive therapy, right? So a few of the designs are shown there, where you can appreciate that patients that are ctDNA MRD positive after neoadjuvant therapy and definitive surgery can be randomized to different interventions, and this can happen in trial design that includes both ctDNA positive and negative arms, or in trials that enroll only ctDNA negative or ctDNA positive patients. Well, the question is, are we there yet, right? And I would say that certainly we have work to do. So we need to study the clinical sensitivity of ultra-sensitive tumor-informed approaches that are coming out. We need to determine when we should measure ctDNA MRD. Do we need to measure ctDNA MRD once or twice over time? So this is work that we still have to do to inform the next gen of ctDNA-informed clinical trials in the early stage setting. So in order to answer some of these questions and enable, in my opinion, ctDNA interventional trial design in the early stage setting, Charu Agarwal and myself put together the tic-tac-toe trial, and the name is going to make sense in the next slide. But practically, this is a biomarker observational trial that includes dense blood and tissue collections that is put together with the primary goal to define ctDNA MRD, define the clinical sensitivity of ctDNA MRD in different settings across patients with early stage non-small cell lung cancer, and determine its timing and obviously correlation with 2 years, 2-year DFS, CFS, and OS that represent the primary endpoints of this trial. So then in thinking about the treatment landscape of patients with early stage non-small cell lung cancer, that Rose, you showed, before in terms of where we are, what are we doing. The way I see it, at least, is in my mind, it's converted to a tic-tac-toe board, right? Where, in my opinion, ctDNA can actually be used to inform therapeutic decision-making. And so you can imagine ctDNA being the opening move, right? Determining what do we need to do, surgery first, neoadjuvant first, but then continued evaluation of ctDNA actually helps us to align the markers, and this is a winning strategy for our patients. So with that, I will leave you, and of course acknowledge the great work of folks in my lab that are shown here. In the middle, obviously folks in thoracic oncology at Hopkins, all the BR36 CCTG investigators, and all of you for your attention. Thank you.